Hello, QGR readers. I'm Jie Lee from Seoul National University Hospital in Korea. I would like to introduce our study entitled Impact of Thyroid CT on Detecting Macroscopic Nodal Metastasis in Patients with Papillary Thyroid Microcarcinoma. The incidence of PTMC has rapidly increased with the widespread adoption of imaging modalities, and guidelines from various countries increasingly support active surveillance as an alternative to immediate surgery in patients with low-risk PTMC. Most of these guidelines commonly define low risk as tumors without clinically evident lymph node metastasis, distant metastasis, local invasion, high-risk tumor location, or aggressive cytology. The presence of cervical lymph node metastasis has traditionally been regarded as an indication for immediate surgery. Among those with lymph node metastasis, the recent American Thyroid Association guidelines recommend against prophylactic central neck dissection for clinically node-negative PTMC, aligning with previous studies demonstrating that microscopic lymph node metastasis, which stands for metastatic tumor foci, size similar or less than 2 mm, exerts minimal prognostic impact on patients. In contrast, accurate detection of macroscopic nodal metastasis would be still important and is essential for appropriate risk stratification and the correct identification of patients suitable for active surveillance. Ultrasound is the primary imaging modality for nodal evaluation in patients with thyroid cancer. However, its limited sensitivity often leads to uncertainty in clinical decision-making. To address this limitation, CT has been adopted as a complementary imaging tool, and recent meta-analyses have shown that combining CT with US increases sensitivity for detecting central compartment lymph node metastasis compared to US alone. Although US is gaining clinical attention as a management option for low-risk PTMC, the limited sensitivity of US remains a potential barrier to its broader adoption. Although several guidelines recommend complementary CT in advanced thyroid cancer, its benefit in the routine evaluation of US node-negative PTMC, which is often considered as low risk, remains unclear. Moreover, most previous studies focused on the diagnostic performance of CT for overall lymph node metastasis rather than distinguishing macroscopic disease. Therefore, in this study, we aim to assess whether combining CT with US improves the detection of macroscopic lymph node metastasis and determines the appropriateness of active surveillance in patients with PTMC, particularly for those with US node-negative disease. Let's move on to the materials and methods. This study was a retrospective observational study. Consecutive patients with PTMC who underwent preoperative US and CT between August 2016 and January 2020 were included. We excluded patients with primary tumor with a maximal diameter larger than 1 centimeter on US, no further management after diagnosis at our hospital, and who had other concurrent malignancy were excluded. For the patient with low-risk PTMC, endocrinologists with more than 10 years of thyroid-specific experience provided detailed counseling on current management options, including surgery, active surveillance, and also radiofrequency ablation using a decision aid. Patients who underwent non-surgical management or neck dissection were subsequently excluded. For image analysis, nodal classification for US were based on official radiology reports generated at the time of the initial examination. Two board-certified radiologists retrospectively reviewed all CT images were blinded to the clinical information, US reports, and pathology results. The discrepancies were resolved by consensus during the joint review sessions, and based on the KSTHR guideline, lymph nodes were classified as probably benign, indeterminate, or suspicious. A test-positive lymph node diagnosis were defined as the presence of any suspicious features on a single modality or on either modality in the combined analysis. The results of the surgical histopathology was regarded as the reference standard of this study, independent of the preoperative biopsy results. All patients underwent a total thyroidectomy or lobectomy with neck dissection. And surgical pathology reports documented tumor characteristics, including the type of surgery, primary tumor characteristics, lymph node characteristics, and pathological TNM staging. The lymph node size was categorized as microscopic lymph node metastasis and macroscopic lymph node metastasis based on the largest dimension of the metastatic tumor foci. For statistical analysis, the number of patients with clinical N1 and pathological N1 disease were assessed per patient-based analysis. To compare the diagnostic performance of imaging tests for detecting cervical lymph node metastasis, the sensitivity, specificity, positive predictive value, negative predictive value, and diagnostic accuracy were calculated. Further analysis was conducted specifically for macroscopic lymph node metastasis. To evaluate the added value of CT in case of discordant nodal staging between US and CT, we assessed which modality correctly predicted the presence of macroscopic lymph node metastasis. To assess the impact of adding CT in cases missed on US, the diagnostic performance of CT was evaluated in patients with clinically node-negative findings on US according to the final nodal staging. Let's move on to the results. This table summarizes the baseline characteristics of the study population. 982 patients who underwent surgery with neck dissection were included in this study. Pathological analysis confirmed that cervical lymph node metastasis was confirmed in 377 patients, including macroscopic lymph node metastasis in 187 patients. This table summarizes the diagnostic performance of US and combined US plus CT for detecting the cervical lymph node metastasis. For detection of overall cervical lymph node metastasis, integrating CT with US increased the sensitivity compared to US alone from 14.9% to 42.7%, although US alone maintained a slightly higher sensitivity than combined US plus CT diagnosis. Notably, all imaging modalities demonstrated a high specificity in detecting cervical lymph node metastasis. For the detection of macroscopic cervical lymph node metastasis, the addition of CT to US significantly increased the sensitivity and diagnostic accuracy compared to US alone, while maintaining a high specificity despite a significant reduction. This table summarizes the discordant nodal staging findings between CT and US based on the presence of macroscopic cervical lymph node metastasis. Discordant staging was observed in 149 patients. Among these, 131 were upstaged based on CT findings compared to US, while 18 patients were downstaged by CT. In the CT upstaged group, CT correctly identified macroscopic lymph node metastasis in 80 patients. Specifically, among patients with US cN0 tumors, CT correctly identified US undetected macroscopic lymph node metastasis in 78 cases. In contrast, CT overstaged 41 patients. In the CT downstage group, CT correctly excluded macroscopic lymph node metastasis in 13 patients, thereby correcting false positive diagnosis made by using US alone. However, CT failed to detect macroscopic lymph node metastasis in 2 patients who were correctly identified by US. This table summarizes the diagnostic performance of CT for detecting central and lateral lymph node metastasis in 909 patients with clinically US cN0. Across cervical compartments, CT demonstrated high specificity and positive predictive value for identifying pathological N1 disease, with a corresponding trade-off of a relatively low sensitivity. Notably, CT was particularly effective for identifying lateral cervical lymph node metastasis in US cN0 patients without any reduction in the diagnostic specificity. For macroscopic lymph node metastasis, CT demonstrated a sensitivity of 56.9% and a specificity of 93.5%, detecting additional macroscopic lymph node metastasis in 78 patients, overall of 8.7% among 895 US cN0 cases. Let's move on to the discussion and conclusion section. Accurate nodal staging is essential for selecting candidates for active surveillance in patients with PTMC. However, US alone still shows limited diagnostic accuracy in identifying clinically significant nodal disease. In this study, we evaluated the added diagnostic value of preoperative CT, particularly in patients with node-negative US findings. The integration of CT with US improved the sensitivity for detecting macroscopic lymph node metastasis compared to US alone. Most importantly, CT identified additional macroscopic lymph node metastasis in 8.7% of patients with node-negative findings on US. So in conclusion, in our study, the integration of CT with US improved the sensitivity of detecting macroscopic lymph node metastasis in patients with PTMC, identifying those who would be inappropriately considered candidates for active by US alone. These results support the use of CT as a complementary imaging modality to US for differentiating between active surveillance and immediate surgery in patients with PTMC. Further prospective multicenter studies would be required to define the clinical utility of CT in this patient group. Thank you very much for your attention.